All right, good afternoon, everyone, and welcome to today's Conversation Series program, where we'll focus on the ethical arguments for and against DCD-NRP while comparing international contexts with specific attention to the rights and interests of potential donors and authorizing family members. My name is Deanna Fenton, Senior Manager of Program Development and Operations here at the Alliance, and I'd like to formally thank you all for joining us today. Now, before we begin the discussion, I'd like to encourage all of you to save the date for our upcoming specialized one-day summit on the evolving state of normothermic regional perfusion with respect to thoracic and abdominal organs. This one-day event will be a fast-paced exploration of NRP from multiple perspectives, including legal, ethical, and clinical aspects. We look forward to bringing together the community for this very important discussion, which will be held on March 21st in Philadelphia, Pennsylvania at the Gift of Life Institute. Registration and details pertaining to the event will be posted on our website and shared through our communications in the coming weeks, so stay tuned. Now, before we begin, I'd like to remind everyone that this is intended to be an engaging conversation, and we certainly want to hear your thoughts. That said, should you have any comments or questions that you'd like to share, please feel free to submit them at any point in time using the chat box. Now, for those of you who may be new to Zoom, please note that the chat box is located at the very bottom of your Zoom window. Now, to begin today's program, I'd like to welcome our moderator, Candy Wells, who serves as the Director of Organ Utilization at Life Center Northwest. Candy, as always, we appreciate you for being with us today. And at this point, I'll turn it over to you to get us started.
Present our great speakers today. And I'm going to do a little bio, and then each will be doing a presentation, and then we're going to have a really engaging conversation about the real ethical questions in and around NRP. So first, I'm going to introduce Dr. Alex Manera. He's been a consultant in intensive care medicine at the Regional Neuroscience Intensive Care Unit in North Bristol NHS Trust since 1990. He was a member of the Academy of Medical Royal College Working Party on a code of practice in diagnosis and confirmation of death. He led the implementation of one of the first controlled DCD programs in the UK in 2002. He has been involved in the development of national and international guidance on death determination and on DCD. He's also been involved in the development and guidance of best practice strategies and many other aspects of deceased organ donation. He's been an expert advisor on organ donation at the UK Facility of Intensive Care Medicine and the National Quality Lead for Organ Donation in the UK. I also want to introduce Brennan Parent. He's the Director of Transplant Ethics and Policy Research and Assistant Professor of Bioethics in the Division of Medical Ethics with Joint Appointment in Surgery at NYU Grossman School of Medicine. He serves as an independent living donor advocate and provides ethic consultation for transplant programs across the U.S. He's Editor-in-Chief of the Health Law Journal in New York State Bar, the Bar Association, a fellow of the Center of Genetics and Society, and a member of the Tri-Sci Embryonic Stem Cell Research Oversight Committee. In addition to transplant ethics, Parent's current work focuses on ethics for crisis resource allocation, ethical challenges surrounding big data and artificial intelligence in health research, and regulation of emerging medical technologies. He's published academic articles in peer-reviewed journals spanning law, medicine, science, sports, and ethics. And his work has been featured in the Washington Post, the New York Times, Chicago Tribune, The Guardian, and NPR. Previously was a legal fellow in the New York Task Force on Life and Law, the first Rudin postdoc at NYU Division of Medical Ethics, and received his JD from Georgetown University Law Center. So without further ado, Alex, do you want to start your presentation and then pass it off to Brennan? And then we'll start a really engaging, interesting conversation about the ethics about NRP. And thank you.
Thanks very much. If I could have the first slide, what we're planning to do is to just try to put everything in context and set the scene for the discussions that we hope will arise as a result of this. NRP is a new technology, or within the last decade, developed basically to reduce the warm ischemic damage that occurs to organs that are going to be transplanted DCD. And in so doing, it will hopefully improve the transplant outcomes and increase utilization of organs. And whenever we talk about this, can I have the slides up, please, if possible? Whenever we talk about the ethics of NRP, two things usually come up. The first is the donor really dead? And the second is whether NRP itself is ethical. And I'll try to answer this as best I can in the short time I'll do this in. Now, the answer to the first question must be yes, the patient must be dead. We want to respect the dead donor principle, which says that the donor must be dead before the organs are retrieved. Otherwise, that retrieval process could be considered to be the cause of death for that patient. And the second question as to whether NRP is ethical or not, I think I'd like to convince you that the answer is yes as well. But to get there, we need to understand as one principle that dying is a process. It isn't a single event. The event is death. And that is something that we define as a time within that process. And that is usually defined as the point of permanence rather than the point of irreversibility, which I'll explain in a second. Can I have the next slide, please? Now, it may come as a surprise that despite something like 60 million deaths on this planet every year, we still don't have a universal global definition for what death actually means. But more and more, we're moving away from quite confusing anatomical definitions like whole brain, brain stem, higher brain death, and trying to come to a more unified concept based more on the loss of function. This is one such definition. It was developed at a meeting under the auspices of the World Health Organization and Canadian Blood Services. And as you can see, death is defined as the permanent loss of capacity for consciousness and all brainstem reflexes. This is very similar to the definition we have had in the UK for a couple of decades now, where we define death as loss of the capacity for consciousness plus loss of the capacity to breathe. In other words, it's functional. All death is located within the brain rather than other organs. Can I have next slide, please? And this means if you adopt these definitions, this leads to two further concepts. The first is that all death is the same. There isn't cardiac death, circulatory death, and brain death. Death is a permanent loss of the capacity for consciousness and permanent capacity to breathe, and that is death. What differs is the criteria used to diagnose it. We're diagnosing the same death, but depending on the circumstances is what criteria we choose. So obviously about 1 in 400 deaths will get the criteria, the death confirmed or determined using brain criteria. And this is doing the tests, if you like, the clinical tests to confirm death. This is confirming that death has already occurred. It's a retrospective diagnosis that death has happened. Or alternatively, something we call the somatic criteria. This is when you can recognize that death has already occurred, again, a retrospective diagnosis, because you can see it from just by external examination of the body, things like rigor mortis or injuries that are incompatible with life, say hemicorporectomy or decapitation or really bad burns, charring the body. And finally, there's the circulatory determination of death, which is probably more relevant to today's conversation, where the diagnosis is prospective if you are there from the time of loss of the circulation, cardiorespiratory arrest. In other words, death may not have occurred, but unless you do something to restore the circulation, then you have no doubt that the patient will achieve those criteria for death, the permanent loss of capacity for consciousness and capacity to breathe. Next slide, please. The second concept is that because dying is a process, we can decide where along that process, we want to declare that. And we can declare it at the point of permanence or the point of irreversibility. Now, permanence is the time at which the dying process will not be reversed. And in CDCD, this means that you are not going to resuscitate the patient. You have made a decision to withdraw life-sustaining treatment and won't restart the circulation. And also the time for the circulation to return spontaneously has also passed. Whereas irreversible means that you cannot restore the circulation and brain, as a result, brain functions, whatever you do. Next slide, please. And basically, as long as there's no intervention that interferes with the dying process, then the point of permanence is in effect same as the point of irreversibility. Next slide, please. However, any interventions that potentially restore cerebral perfusion will interfere with the dying process, and therefore you cannot assume that permanence and irreversibility are the same. Next, please. And NRP has that potential, but there are obviously things you can do to prevent the dying process being interfered with in your surgical technique. Next slide, please. And to show this in another way, this is what happens in real life, in everyday life. A withdrawal of life-sustaining treatments decision has been made. Ventilation is stopped, patient possibly extubated, drugs stopped, and eventually you reach the point of asystole. And from that time on, you have 5 minutes in which this is usually called the standoff time, an observation period, during which time you watch the patient to ensure that there's no return of the circulation or respiration. And after 5 minutes, and this is now based on pretty good science, there is no chance of the circulation coming back spontaneously. However, we know that it can be restored through intervention, but if there's no intervention, there's nothing that can restore circulation to the brain in particular, then that process will carry on into complete irreversibility. The problem with irreversibility is it is very difficult to define when it occurs, and it is likely to be different for different patients with different comorbidities, like diabetes, cerebrovascular disease as well. And the point of permanence is very much the point that is used in everyday clinical practice, irrespective of the potential for organ donation or not. Next slide, please. So NRP, as I said, had the potential to restore cerebral perfusion unless you modify your surgical technique. I won't go into the surgical technique as such, but there are two issues. The first is that your clamps may be positioned incorrectly, which means you can get flow to the brain, or alternatively, there could be flow which could be occurring through the establishment of collaterals, usually through the intercostal vessels, anastomosing with the vertebrobasilar system, but these can be done. And if you can find a mechanism to do this, and there are a variety of means proposed to prevent any of these things from happening, then there are benefits of NRP, both abdominal and thoracoabdominal, which make it an attractive proposition. The first thing is that it reduces the warm ischemic damage caused during the dying process. It helps organ repair, and perhaps one of the more important things, particularly when it comes to heart transplantation, is that will allow better functional assessment of the organs. And these benefits will translate into real better outcomes for patients. More organs are utilized because surgeons can have a greater confidence in the suitability of the organs for transplantation. It can improve transplant outcomes, and we're getting to the stage where the DCD outcomes in the presence of NRP will actually match those of DBD organ outcomes, to the extent that within certain countries in Europe now, it is mandatory to use NRP for DCD liver donation in particular, and potentially it will increase in others as well. Next slide, please. So the question arises, is it ethical to exclude the brain circulation after the confirmation of death? The patient's already dead, I hasten to add, but people raise concerns, and I think they are valid concerns, obviously, to raise as to whether clamping vessels is actually the cause of death, or whether we are increasing the invasiveness of the procedure to facilitate exclusion of the cerebral circulation. Next slide, please. I think it is yes, the answer to that question, and I'll explain in a second why I think so. The first thing is that it is certainly possible to justify it ethically if you accept the definition that I have said. What is being done to someone who has already been confirmed dead by criteria that, as I said, are used in everyday clinical practice. Any clamps that are attached after death has been diagnosed and before establishing circulation to the organs themselves. So the patient was dead, and what is being done is applying clamps not to kill the patient. The patient is already dead and has died from the devastating brain injury rather than from any procedure we are doing, and the brain injury that led to the decision to withdraw life-sustaining treatments. So the clamps aren't causing death, but what they are doing is allowing the dying process to continue without interference, because we are not allowing the brain circulation to return and interfere with that presence. And that will maintain the permanence of the diagnosis of death as we have defined it. And it's also worth saying that this is in keeping with the wishes of the family, of the patients themselves, in having made that decision to withdraw life-sustaining treatments, that they did not choose to be resuscitating. And we are ensuring that that doesn't happen and not interfering with the dying process. And the last slide, please. And to me, I think part of the problem is potentially more of a legal issue rather than necessarily just an ethical one. Next slide, please. And the reason I put this up is because I think it's possibly more of an issue where definitions of death are based on irreversible cessation of circulatory and respiratory functions. Like there are two types of death, either a brain death or a circulatory death. There is one death, and if you accept that this should no longer be an issue. But when it's enshrined in law, then that law needs to be looked at. And I will end here because this is primarily a US issue, which I'll let Brendan talk to. Thank you very much.
So thank you, Alex. That's a perfect setup for what I hope to cover. And you cover all of the issues eloquently and thoughtfully. I'm going to share my screen here. And could I get a nod if you can see this in the appropriate format? Great, thanks. So yeah, I think that's just such an excellent overview of the process, the questions, the considerations from a global perspective. And I hope to perhaps hone in a bit more on the US jurisdiction, the questions around how this should be considered in the unique United States culture and context. So here are my disclosures. Doing a fair bit of grant work on various DCD techniques. And I should probably also mention, it's not on here, but NYU is one of the programs that has implemented NRP DCD. I don't work with them. I helped consult with them thinking through the ethical questions. They don't give me any money, but to the extent that some people think that's a conflict of interest, it's important for you to know. And I think it's important to zoom out for a moment and think about why we even need to go here. And obviously, here's the reason, right? We still don't have nearly enough organs. How do we get more good quality organs? And one method is more DCD recovery. And there have been some estimates that if DCD were implemented more widely, that we could increase the organ pool by up to 20%. And that's huge. So what is the traditional method for DCD, and why isn't that sufficient? Why do we have to think about NRP? And part of the reason is the rapid recovery technique has some major challenges, which is when the heart stops, when circulation stops, the organs start dying immediately. So there has to be a very quick recovery and slowing of ischemia, usually through cold transport, getting it to the recipient, and then crossing your fingers, right? And hoping that the outcomes are good. So the idea was to innovate on this. But before we talk about NRP, I think it's important to go back to some of the overarching and continuing ethical considerations around DCD. And this first one, I think, is very relevant to NRP, which is about timing and the idea that the conversation around withdrawal of life-sustaining treatment, which means that the family and the clinical team mutually arrive at the decision that this patient's life is over, that the dying process exists, is happening now. And I like Alex's distinction between dying as a process and death as the moment, the determination, so that we can then go into the donation conversation. But there are important logistical issues here, right, in the US context, which is that there's a firewall between the individuals who are responsible for having the conversation about withdrawing care and allowing death to proceed, and the individuals who come in to talk about organ donation. And that firewall exists to preserve trust in medicine in a healthcare context where healthcare is a business, money is made, and we want to make sure that the patient population, the donor families, don't think that organ donation is driven by financial considerations or anything other than the patient's well-being. So there are practical questions around how to make the decision to withdraw life-sustaining treatment and then park it long enough, the actual execution or implementation of that decision, so that someone, the OPO rep, can come in and talk about organ donation. And then we have all these questions about, well, what kinds of things can you do to the body before death, such as cannulation and administration of heparin, that comport with the duty to care for the patient and promote their well-being, while also promoting good outcomes post-donation. And then this hands-off period, right? What amount of time needs to elapse between the moment that the heart has stopped and the moment that organ recovery can begin? Alex referred to 5 minutes. But there are some programs which say 2 minutes, some which say 10, some which say 20. And all of these determinations have implications for the quality of the organs and for the question around, well, has it been long enough to ensure that auto-resuscitation isn't possible and that this patient is in fact dead? So I'm just putting these all back on the table just to keep in mind, because these continue to be relevant no matter what kind of DCD you're doing. And then the long-standing question about, recovering the heart after DCD. If you use the heart, i.e. the locus of circulation, to declare death, and then you restart the heart regardless of where, in the recipient, anywhere else, does it undermine the death determination? And I think largely in the community, the ethics and organ donation communities, this has been resolved to say, look, just because the heart itself can work in the recipient, that it can be the locus of circulation for someone else, doesn't mean that it has any capacity to work in the donor. So it's not possible to restart circulation meaningfully in the donor. Okay, well, what about ex situ perfusion? Right? We have these machines where after the donor has died, the hands-off period has elapsed, you can recover the organs and put them on these machines outside the body to reperfuse them, hopefully mitigate some of that ischemic damage, and then transplant. And it's a great technique. It's incredibly important, but there are some limitations in terms of cost, in terms of the resources to run the machines, making sure that there's someone trained to be able to do it, and to understand how those organs will work in the context of a body. And so that's where there's some value, additional value of NRP. And so when I say NRP, I am referring to TA, thoracoabdominal. There are other NRP methods which just perfuse the abdominal organs and not the heart and lungs. But we're talking about the ethics questions that are unique, I think, to TA NRP. So as Alex mentioned, I'm not going to go through it, right? We're occluding blood flow to the brain after the hands-off period has elapsed and restarting circulation in the body, which can potentially mitigate ischemic damage just as well or better than XC2 and allows time for organ evaluation under physiologic conditions. Okay, great, but does it undermine the definition of death? And we heard Alex's arguments, which I think are fantastic, and to hear about the definition of death, about capacity for consciousness, and how it can be either by circulatory or brain criteria, but ultimately it's all about the loss of the capacity for consciousness. Well, as Alex mentioned, in the US, death is defined legally a little differently. It's either irreversible cessation of all circulatory and respiratory functions or irreversible cessation of all function of the entire brain. In NRP, death is declared by cardiorespiratory criteria, right? And then blood flow to the brain is occluded, and then circulation is restarted. So do those steps comply with this legal definition? And the definition itself, the letter of the law, talks about irreversibility. And irreversibility means the heart is stopped and it cannot be restarted. Well, clearly NRP doesn't comply with that. But what about the permanence standard that Alex described? The heart has stopped and we will not attempt to restart it, right? It's not going to be restarted. Well, why? Because doing so would be medically ineffective. This patient does not have the capacity for life to be discharged, to have consciousness again in any kind of meaningful way. When the support is withdrawn, the heart stops. It cannot beat spontaneously. So we make a decision, the clinical team and the donor family, in accordance with that patient's wishes, to proceed with the death process. So is NRP any less permanent than either ex situ perfusion or rapid recovery in any meaningful way that should make us concerned? Even though circulation is restarted in the body, there's no capacity, right, for the heart to restart on its own, and we're not going to try to restart it to resuscitate the patient. So this question about reanimation, are you undermining the definition of death by restarting circulation? One argument is yes, you restarted the heart in the donor's body. So by the letter of the law, you have restarted circulation when we said that circulation was stopped permanently. To the contrary, we can say, well, look, the heart wasn't resuscitated, right? We're not bringing this patient back. Instead, it was perfused for donation. And some might roll their eyes and say, okay, look, you're just playing with the definition of death. You're gerrymandering, you're using, linguistic acrobatics. I think it's important that intention is read into that definition of death that I gave you, which is irreversible cessation of a cardiorespiratory functions. Well, what does it mean for it to be irreversible? It means that the heart and circulation has stopped, and we will not try to restart it because doing so would be medically ineffective for the patient. So you'll see a poll up on your screen. What do you think? Does recirculation for NRP undermine the determination of death? Yes, no, or are you not sure? So this is just for fun. Anecdotally, we'd like to see sort of what the audience is thinking. Any other thing to talk about on that poll, Deanna? Or I think we should just move on. That's pretty straightforward. Oh, and then here's some stats already. Sweet. Okay. And obviously, we have an audience here who I think has been around this issue and is interested in it and might be from a particular camp. But there's some dissent here, right? Some who say, yeah, this actually is a problem, maybe legally and ethically, and then others who are not sure. So this is great. I'm looking forward to keeping those stats and revisiting them. And for those of you who do have this concern, right, let's talk about it. Bring up your particular questions at the end here. Okay, well, what about compliance with the dead donor rule? Back to Alex's point that organ removal can't cause death, or you can't cause death in order to get organs. So does preventing blood flow to the brain, the act of preventing the blood flow, does that cause death? And one argument is yes. If you're doing it, you're complicit because you are ensuring, right, that death has occurred by neurologic criteria by cutting off that blood flow. To the contrary, we say, at least in the US context, look, the patient was already dead according to cardiorespiratory criteria. We declared them dead in accordance with accepted medical standards. Everything after that is about perfusion and preservation and donation. It's not, there's no sort of capacity to say that this patient is alive because we declared them dead in an acceptable way. So what do you think? Does preventing blood flow to the brain cause death? And maybe we can take a peek at those results. So wow, the vast majority say no, and then 3% say maybe, we're not sure. Okay, so that's even more from a particular camp. We're I guess preaching to the choir, but I don't want to be preaching because I respect the questions and concerns. We have to figure out first whether this can be done in an ethical way, and if so, how to do it in the most ethical way. There have been some who have proposed that we should abandon the dead donor rule, which is, you know, this notion that organ donation cannot cause death, or that the person, you know, that we can't facilitate death in order to get organs. Well, if the issue is whether the patient is in fact dead, some say, look, no, Brendan, your arguments are ridiculous. The patient is not dead in a meaningful way, but maybe that's okay. Maybe it's still ethical to say the patient isn't dead, but organs can still be recovered as long as other ethical foundational requirements are met. That's one possibility. Here's what I care most about. I care most about what it means for informed authorization for NRP. When we talk to family members about what's going to happen here and what is necessary to make organ donation possible when neurologic criteria will not be met on its own, that the patient is going to die, and that organ donation can happen, and we want to ensure optimal outcomes, what is the morally relevant information to tell them? Does the family need to know that circulation will be restarted in the body? Do they need to know about occluding blood flow to the brain? Is it too much information that would be too burdensome? But if you're not telling them, are you preventing the relaying of critical information that would inform their decision? So I think I know probably the answer to this question generally, but would you agree? Think about this. Put yourself in the shoes, not of the OPO or the clinician or the hospital, but as your family member, right? Would you agree to this, knowing what you know, which is probably far more than the average, you know, donor family member? And then we can talk about why or why not. So what information are we obligated to give? This is something that I'm looking to study. And so I want to finish with this point, which is, I think the key issue is trust in the US context, that there are key reasons why there are problems of trust in medicine and in organ donation, some of which are valid because of histories of abuse and discrimination, specifically of marginalized patients of color, that need to be respected, right? Which means that the donor families and the patients have to be partners in the process, and they have to be empowered to make decisions based on adequate information. So I want to go back to this notion of permanence. Regardless of the trouble that we have with the exact definition of dying as a process or death as the determination, I think it all hinges on what permanence means. That if there is a legitimate decision that is as objective as possible, based both on clinical factors and what this patient would want under these circumstances, to withdraw life-sustaining treatment And to ensure that that decision is warranted because there's no chance of any kind of meaningful life or recovery, that the heart will not be able to sustain the body. And if so, if that criteria is met, and then withdrawal happens and the family is on board and the patient is on board with organ donation, then there might be a duty to ensure optimal recovery through methods like NRP. And I'll stop sharing there. And I know this is supposed to be a conversation series, so let's have a conversation. Okay, so who would agree to it? Well, potentially fewer than those who might sort of believe that the NRP criteria are met for ethics considerations. There still might be something funky that you feel, right, when authorizing this, yes or no. All right, so I'm going to pass it back over to Candy to lead us through some discussion.
Great. And I see Alex is back on too, which is awesome. And please put your questions in the chat. So to get us started, can both of you respond to what you think are maybe the most important or two most important questions that have to be resolved for NRP to become just accepted pretty much as how we might move forward on DCDs in the US. So what are the questions that you believe, the ethical questions that you believe are the most important to resolve the current challenges we have in and around NRP?
Go for it, Alex. Okay, I'll go first. Well, I think there are definitely a couple, and they're not just ethical; they transcend that as well. But I think there's need for actual clinical proof about the effectiveness of the techniques we use to exclude the cerebral circulation. There's a lot of encouraging work that's already been done. There's been work on pigs suggesting that even just clamping the arch vessels is adequate to prevent any blood flow or reperfusion or function of the brain. And we need to show this not just with clamping, but also with drainage to atmosphere to actually increase, if you like, the safety of the procedure. A lot of that at the moment is hypothetical, apart from 3 case studies that we presented in a paper a couple of years ago and the big study. And I think once that is out there, if you like, then I think the evidence about the benefits of NRP, both abdominal and thoracoabdominal, to the recipients, the utilization rates, the assessment of function translating into better transplant outcomes will become much more relevant and much more convincing. And we also need to address whether NRP techniques are better than ex situ techniques. Again, this evidence is emerging. I mean, not just for the cost benefits, which are so obvious in that one machine of NRP can reperfuse multiple organs as opposed to requiring one set per organ, which makes it very difficult for one thing and also highly expensive. Again, cost isn't the major implication. The most important thing is donor safety, I think, from our perspective, and that's what we want to ensure. Brendan spoke about whether the dead donor rule is relevant. I think to the majority of people, certainly where I am, it's highly relevant, and it would take a lot of convincing people to start retrieving organs from people who are nearly dead but not quite dead.
Great, thank you.
I would agree with all of that. I think all of it hinges on this being effective, right? And if there's data that says this doesn't work to produce better outcomes than either, standard DCD or ex situ, or if ex situ is way superior, then maybe we just have to deal with the cost issues, right? Assuming that the data continues showing that this actually is, a very effective and perhaps superior way, then we have to deal with these other questions. One around, Alex talks about it in terms of safety. What does safety actually mean for a dead donor? And we have to face the truth that there are these questions around restoration of any kind of experience. And if that's possible, then that needs to be known. So I think there need these studies about what actually happens in the brain of the potential donor when the right mechanisms are used to occlude blood flow, and ensuring that that data is public and transparent, and that best practices are shared so that this can be done in the most ethical, safe way. And for me, again, what we need to talk to tell potential donors, obviously, I think preferably before death, all of us on the call, how do we sort of think about this, and then educate the public and share information, and then also talk to donor families in this particularly critical, vulnerable moment. And I'm not advocating for, over disclosure or 100% disclosure of all information, because that's not useful for any kind of donation. There's just some stuff that people don't want to know, and it's not morally relevant. But what factors are critical so that people can make decisions that align with their values and the values of their loved ones?
Great. You talk about what's morally relevant for families. In the conversation that we're having to inform families about what the donation process looks like. And I think one of the questions that I have, and again, I know this might be a little bit rhetorical, but what should that conversation, in your opinion, include? I mean, if there's a family that says, I want my loved one to be an organ donor, and I don't want to know any of the details, then what does that mean for, NRP, insight to? What components do you believe are important for a family to be informed about? And do you think they should be? Is it just enough for there to be authorization from either the donor or the family for heart transplants, for recovery and transplant on a DCD donor?
I have thoughts about this, but I'm curious to hear what Alex, has to say about it.
I think it's a very interesting question, and one I don't think we've tackled particularly well so far. And I think it would be well worth including donor family networks to find out just what they would want to know, and try to tailor our responses according to that, because as far as I'm aware, we don't know that. But if you remove NRP from the procedure, the information given to the family is very much driven by what they ask as much as anything. They understand that the patients, the donors, have an incision, sternotomy going right down to the pubes to expose it. But you don't go about saying, I'm going to clamp the ascending aorta to remove the heart, for example, irrespective of what it's doing to the brain, or I'm going to clamp the inferior vena cava and the renal vessels before I take the kidneys out. So I think it's why there should be a different explanation for clamping. I think I'm not quite sure, unless you're talking to a medical family or someone with a high degree of understanding who's asking those questions, in which case openness, transparency, and honesty is the only approach. I do think, though, that in TA-NRP, if you are restarting the heart and the body, I do believe we should be talking to patients' relatives about this, because the heart still retains this centrality in life and death, even though I'm talking about the brain being the more important determinant of death, which is obviously the case to many lay people. The heart is the source of power, of courage, of love, of life, of all sorts of things. And restarting it in the body may come as a surprise. And you can prepare them for it and saying, the heart is just being assessed. It isn't maintaining life because the person's already dead and it's going to be beating again. There are all sorts of words that can be used. And there's, I'm sure, people who can find better words than I can as to how to explain it. But I would put restarting the heart in the patient's body as something that should be discussed with relatives.
I agree with that. Going back to your hypothetical, Candy, you said, this particular family says, look, I want to make organ donation possible. We don't want to know. Alex answers well, which, says, look, it depends. It's driven by what the family wants to know. And if they say they don't want to know, I think that's very important. However, even if families say we don't want to know, there might even be certain things that there's sort of this duty to say. And I think Alex is right that, look, we actually probably should say, you say you don't want to know, but I think you probably have to know in order to make a truly informed decision. For example, that the heart is going to be restarted in the body, because maybe you didn't know to ask or to even consider this possibility, and that might actually have some sort of resonance for you in an important way. What else do families want to know? Well, whether they think they want to know or not, they probably want to make sure that their loved one isn't going to experience any kind of harm or suffering, right, as a result of donation. And if we can guarantee that, then that's critical information that informs what's going to be told to families. So I think it's important to know whether we can guarantee that and how to ensure that we can guarantee that. Before all of this, a critical piece of morally relevant information is whether the family believes in death by neurologic criteria, right? And Alex's presentation and my intuition, my feeling, my beliefs go to this notion that all death is about capacity for consciousness, right? And the loss of neurologic criteria, because that's the locus of all of our experience and sensation and sentience and everything else. But there are some who don't believe that, right? And not just fringe, there are significant populations who say, look, it's about the heart and that's what matters, for all the reasons that Alex just mentioned. Well, if that's true, we're not going to even approach this family, I think. Well, actually, no, I'm sorry. It's actually the opposite, right? So that maybe, DCD might be the only method by which some families are willing to consider donation for their loved ones. But, whether this, families who don't believe in neurologic death would agree to NRP versus rapid recovery, I think is morally relevant.
So on that note, should families be given the opportunity to either choose, insight to, or like OCS, like your loved one can donate, their heart, and there's two ways it might be done. Should families have an opportunity to choose which option might be used? I know we're talking more about, recipient outcomes and the cost of, OCS or machined perfusion, I should say, as it compares to in situ perfusion. So is it a transplant center decision, or is it also a family's decision to decide what might be appropriate for their family? I told you I was going to have not just easy.
Oh, it's great. No, this is great. And I believe, and I thought about these, and I think logistically, I'm just wondering, Alex, do you know of any programs that are, that are pursuing and have in situ and ex situ capacity, and or are doing rapid recovery all at the same time, right? To even make this hypothetical possible and what it would look like to have these. Do you know of programs that are doing, all of them?
At present, there's just one centre that I'm aware of in the UK that does it, and that's Papworth. It's the only centre that does TA and RP. There's a couple more that use the ex situ machines as well. I think it's a very interesting question, and it comes to the gift as much as anything else. Should it be conditional? And there are so many factors that would influence this. I was quite interested about, the heart and whether it starts in the body or not. And we do know, for example, that something like 1 to 2% of all our patients who are confirmed brain dead and consented for organ donator will go down a Maastricht 4 category donation, because the family may have accepted brain death, may not, but they want to be there at the moment that the heart stops. So we do know that this is crucial, that is very important to some families for whatever reasons, whether it's cultural, religious, whether it's the understanding of death, whatever the reason, it's difficult. And you could take the attitude that if you say, no, we must start the heart in situ, then potentially the family is going to withdraw their consent, you know, and you need to bear that in mind. But equally, not all centers, not all transplant programs will have unlimited availability of machines as well, and unlimited resources to do that. So it is a difficult question, and I'm not sure I have the right answer for it. We want to give patients, relatives, as much choice as possible, but it has to be balanced with other things as well.
And the only thing I'll add to that is, especially again in potentially US context or even anywhere, concerns about invested interests driving clinical decisions or outcome decisions. You know, one hospital happens to have a relationship with, you know, the organ care system, you know, Transmedics or whatever it is, that influences, okay, well, this is the option simply because, you know, we have something financial to gain from this. I think there is some value in potentially having all the various options to dispel any, you know, unfounded or potentially at least, you know, partially founded concerns about these conflicts of interest driving the decisions. And if families, you know, to the extent that we can respect families' beliefs, whether religious or moral, and how that might, as Alex says, say, okay, well, look, we want to be able to donate organs, but we don't want you restarting the heart and the body. I think that potentially should be respected, and then provide another option. But there are some lines that we have to draw, right? Families can't decide everything about the course of care.
Great.
Could I just come back on that, Ken, if that's okay, just briefly? I think these discussions are also driven by the fact that we don't have all the data and knowledge to suggest that one is definitely superior to the other. I think once that becomes available, then you may have a much stronger argument, families as well, that look, he wanted to be a donor, she wanted to be a donor, wants to donate heart. We know that this system will provide a better outcome for the recipient than the other system. When that's available, I think the discussions will be driven by that as much as anything else. And families do respond to that, because why would they want to donate if the transplant's not going to be as effective?
Absolutely. No, I think that's a really important point. So we have a question. So what about social justice aspects of cost, allowing for more transplants? So comment, question, what are your thoughts even around that? And Brennan, I'll have you go first.
Sorry, with me? Is that you calling me?
Yeah, I'll have you go first.
Yeah, I was kind of lost in thought about the various social justice implications. Well, what's critical? One, that families don't have to bear any cost for any of this, and that the mechanisms that are used to actualize, to make organ donation possible, don't favor any particular group, right? So that, you know, certain individuals are not funneled into one particular kind of recovery versus another. So I think that's important. I don't, you know, what I think about when I think about social justice in this context goes back to ensuring consistency in determinations that continued care for a potential organ donor, i.e. a patient, are objective and consistent across different individuals. The last thing in the world that we want is to have two similarly situated patients who are both approaching the end of life, and for different clinical decisions to be made for those patients, or for their family members to be driven in different directions about the potential for withdrawal because of any implicit biases right? Meaning that, oh, we think, unintentionally that more efforts should be implemented to sustain care for this patient, and this one is being pushed into, potential withdrawal and organ donation, especially if individuals from the same patient group who might be funneled in one direction or another would not be eligible to receive organs in the US context because they don't have adequate insurance, right? So these are the kinds of social justice concerns that I think about.
Alex, do you have comments?
Yeah, I obviously work in a very different healthcare system where insurance or not makes no difference to anything or anyone, really, certainly in organ donation and transplantation, because patients don't have to pay for anything, whatever their earnings are. That may sound like a sort of vague answer, but it's true. Our decisions in social justice are driven by trying to provide maximum healthcare for minimum resources that delivers the same quality, if you see what I mean. We are, in effect, not saving money for the individual patient, but we are saving resources for the whole of the healthcare system for donation, because it's a national service. And I do get that, this difficulty when money becomes involved. It makes decision making very, very hard for everyone involved, not least for families and patients who may have to actually pay for it out of their own pockets.
We have a couple more questions. Do you both have a little bit more time? Okay, great. We have, can you comment on the BrainX paper and its spread into popular media and how this could impact the topic?
Sure. So for those who don't know about BrainX, this is a new research endeavor out of Yale to create a synthetic blood or circulation system with the capacity to deliver different pharmaceutical agents and different pressures, basically to do a better job of circulation than even current techniques like ECMO-based ECPR or NRP, right? Extracorporeal membrane oxygenation uses autologous blood. This uses a synthetic blood. And the data has shown in pig models that BrainX can do a better job of restoring organ function and circulation, and potentially even brain circulation and activity. So that's the background. I will just say that the implications for this mean that we need to be very conscious about how recirculation techniques are developed and researched for life-saving of individual patients versus preservation of an individual's organs, and that we have a moral duty to explore techniques like OrganX, which is the next iteration of BrainX, for the emergency care context, at least in tandem with, if not prioritized over, organ preservation techniques, because we need to prioritize the lives of individuals versus preserving their organs for other people.
Alex, any comments?
Yeah, I mean, just to add briefly to that, I think papers like that are to be absolutely welcomed. Our primary objective as doctors, nurses, healthcare professionals is to save lives, improve lives, and if this sort of technology helps that, then why wouldn't we welcome it? We've been there before with fluorocarbons, which seem to be hailing the dawn of non-hemoglobin-based oxygen carriers. And, the initial work didn't translate into clinical benefits. Let's hope this does. For organ donation, I think the implications are multiple. Obviously, is it safe to use the solutions without clamping the brain vessels? Is it better to use those solutions rather than normothermic regional perfusion to actually further improve the repair of organs subject to ischemic damage during the withdrawal process. I think it's just such an early stage that it would be difficult to try to understand the implications of it to not just organ donation, but to fields like resuscitation, cardiac surgery, and bypass, ECMO-driven, ECMO-assisted resuscitation. There's so many potentials for it. To just limit that to organ donation, I think at this stage would be a bit hard. The potential for it is much, much wider.
So if TA-NRP is problematic because of the possible reanimation of the brain and our inability to determine within 5 minutes whether the brain is dead, what does that say about the use of DCD without NRP as it has been practiced for the last 65 years? Must we conduct some tests for brain function or flow, as some have proposed? Just is that what you think will be the solution?
Go ahead, Alex.
I think, being diagnosing that safely and confidently at 5 minutes for a whole number of years without any problem. As I said, there's something like 60 million deaths on this planet a year, and DCD without use of NRP shouldn't raise any of those issues, because without the circulation present and you removing organs, you're not restoring any sort of circulation, then there can be no brain function. And this isn't just me saying, this is actually proven in many papers. If you stop the circulation, you lose consciousness usually within about 20 seconds. The EEG will go isoelectric within about half a minute, and all forms of evoked potentials will be lost in much less than 5 minutes. So the question really is when there is a circulation in the body as to whether it does that. And I think what I've just said will remain true if you exclude the cerebral perfusion, cerebral blood flow in the presence of NRP. As long as there's no blood going to the brain, then cerebral function, brain function cannot return. If there's no flow, there can be no perfusion. If there's no perfusion, there can be no function, is what we work on. So I think we haven't got a big problem there. I think as long as we understand that when we are diagnosing permanence, we are diagnosing it on the principle that nothing is going to be done to interfere with that dying process. In other words, reanimation, but by re-establishing cerebral perfusion. As I said, there is a lot of work being done to show that this doesn't happen. A paper based on, for example, ECMO-assisted resuscitation. There was a meta-analysis done on that, or a literature search, which found that certainly after 5 minutes of asystole with no circulation, the use of ECMO may have resulted in survival, but no one survived with good brain function. So I think there are things out there. It's not to say that after 5 minutes it's impossible to resuscitate. It clearly is. It's done by paramedics, by medics, all sorts of people, and that's the whole objective of CPR. But unless you're providing that brain recirculation, then there shouldn't be a difficulty. The whole objective of CPR and ECMO assisted resuscitation is to actually provide brain to the blood flow, to the brain and the other organs. And quite often resuscitation continues without the heart working at all. And patients have a heart not doing much and are potentially awake and talking to you.
I think that's a great note to end on. I think there are good standards for deciding that death has arrived and that any kind of attempt to reperfuse the brain would not be medically ineffective, would be medically ineffective. So I think the question, I feel like it might be kind of like a softball. No, we don't have to conduct tests of brain function for people in traditional DCD methods. We know that the brain is done in those capacities. But I'll just, plant a little seed, which is like, well, let's keep an eye on OrganX, right? And see what happens in the development of those technologies to actually restore meaningful function, coordinated electrical activity in the brain, if and when those studies ever come to pass. It is the job of everyone, including the organ donation sphere, to care about those outcomes, right, first. And hopefully it's the organ donor, organ transplant world's job is to make itself obsolete, right? We want to make it so that people don't need organ transplants in the first place. So keep that in mind as we do the good work to expand recovery of organs using innovative techniques.
So one more really fast question. Maybe it isn't really fast. So some OPOs are limiting DCD heart recovery to either not allowing NRP, but maybe they're allowing machined perfusion. Is that ethical? Is it ethical for the OPO to make a decision in how the heart will be recovered?
At this point, I would say yes, right? As the data accumulates, OPOs need to be attentive to the cultures and environments of their constituents, of their partners, right? That doesn't mean that there isn't possibility for translation and uptake of new technologies. But for now, if the OPO decides that this is the way to do it, to be respectful of some concerns that might exist within certain hospitals, sure, that's fair. But if the data changes and as we gather more information, and including public support studies and understanding of how NRP is received by people, then OPOs might have a duty to change their perspectives. But for now, I think that's valid.
Thank you. Alex, any last comment before we close?
I'd agree with that. I think until more data becomes available, it is. And I think we need to bear in mind that TA-NRP is not a simple procedure. It does require a lot of skilled surgeons who are trained at doing this. And they're few and far between at the moment, whereas there are perhaps more surgeons who are trained at doing the quick recovery cold perfusion technique rather than TA-NRP. So machine perfusion might be an easier option at this point for some OPOs, regardless of costs.
Well, thank you. Thank you both. I think it was a really engaging conversation, and I'm sure all of us are leaving with more questions than we have time for. But thank you so much, and thank you for everyone that participated today. And Deanna, do you have anything else for closing?
No, I would just say, well, first and foremost, thank you, Candy. Thank you, Brendan. Thank you, Alex. Again, I think this was a fantastic discussion. And to Candy's point, certainly there may be more questions that folks may have. And so I just want to reiterate again, we'll have our event in March on NRP. And so certainly I encourage all of you to keep an eye out for communications surrounding the details of that event. And if you're interested in joining us, be sure to save the date. Again, that'll be March 21st in 2023 as we kick off the new year. So more to come there. But once again, just want to say thank you to all of you. And with that, wish you all a wonderful rest of your day. Take care, everyone.
Bye.
Thank you.
Take care. Thank you.